Good afternoon and welcome. My name is Kelly Macheska and I'm the National Senior Manager of the Get With the Guidelines Heart Failure Program. We would like to welcome you to today's webinar. It's titled The Top Things to Know for the 2022 Guidelines for the Management of Heart Failure. Thank you all for attending. Before we get started, I'd like to go over a few items so you know how to participate in today's recorded webinar. As you just heard, today will be recorded and we will be sending you out a link within 24 hours also. There are slides and handouts for today's presentation and they can be downloaded. They're on the right-hand side of your screen. If you look down, it says handouts and the go to webinar control panel, so you can see it over there. All participants will be muted to allow the speakers to present without interruption. However, there will be a Q&A session at the end of today's presentation, and we can actively have a great discussion related to the presentation. You will have the opportunity to submit text questions ahead of time by typing them in the questions pane of the control panel. You can send in those questions during the presentation, and we will go ahead and pull those together that we can share in the active Q&A panel discussion. If you would happen to have any technical issues during the presentation, most can be resolved by refreshing your browser. If not, you can go to the GoToWebinar customer service team. And also we have Melissa Clark on here. So please just send a message in the chat and we'll try to help you in any way we can. Now, without further ado, I'd like to introduce today our esteemed speakers and champions for the webinar. Dr. Clyde Yancy, he's the professor and chief of cardiology, vice dean of diversity and inclusion of Northwestern University Feinberg School of Medicine. And Dr. Gregg Fonarow is the professor of cardiovascular medicine and science at UCLA. He serves as a chief of UCLA's Division of Cardiology and the director of the Cardiomyopathy Center and co-director of UCLA's Preventative Cardiology Program. Please see their full bios and their disclosures that are included in the handout. Both physicians have graciously shared their passion, extensive expertise, and leadership with the American Heart Association over the years, and I'd like to thank them for that. They both have served in a variety of roles and leadership capacities and have helped transform heart failure care. So please give Dr. Yancy and Dr. Fonarow a warm welcome, and I'm going to turn it over to you guys. Thank you.
Great. So thanks so much. If we could get this in presentation mode, that would be awesome. And then give me control and we'll get started. So Clyde and I have had the privilege of actually serving on the guideline writing group. And so in April 1st of this year, the 2022 AHA, ACC, HFSA guidelines for the management of heart failure were released. If I could get the next slide or be given control, that would be awesome. The citation for the guidelines will come up shortly. There we go. Presentation mode would be great if possible. Here's the citation for the guidelines. So we will be referring to those, but you can find these online on Circulation in Journal of the American College of Cardiology, as well as the Heart Failure Society of America. The guidelines themselves were chaired by Paul Heinrich for the writing group, and vice chair was Beacon Boskert. Slides aren't advancing for me, so if we could.
Did you try click? I'm sorry, Dr. Fonarow. Did you try clicking twice to see if that helps you gain control of the screen?
Yeah, there may be a lag. We're still not in presentation mode, though. We're just showing this preview. So if you want to take control in advance, that'd be probably good at this moment. Okay, so here's the writing committee members that you can see here. And as mentioned, Clyde and I have the privilege of serving on this group. So next slide. So we're going to go through the nuts and the bolts of heart failure care. So the next slide. Importantly, the guidelines built upon the staging system for heart failure and the previous stage A, B, C, and D. were slightly modified, and recognizing, if we could get the next slide, that'd be great. There we go. So stage A remains the same, but now referred to at risk for heart failure. And these are individuals with risk factors for heart failure, but who do not have structural abnormalities and never had heart failure symptoms, but recognizing there are risk factors and heart failure can be prevented: hypertension, atherosclerotic cardiovascular disease, diabetes. Next. Stage B are those that are with structural abnormalities, but now referred to as pre-heart failure. Individuals also at elevated natriuretic peptide levels, but again, no symptoms, also in this stage B. Next, stage C is those patients with current prior symptoms of heart failure, and as we'll talk about, they can encompass the full range of ejection fractions. Next. Stage D are those patients with advanced refractory symptoms, now referred to as advanced heart failure. Click again, and you can see that in stage C heart failure, we now recognize the trajectories, that there'll be those patients with new onset or de novo heart failure. Some patients that in response to guideline-directed medical therapy will have resolution of symptoms. Those patients are not referred to as having remission of heart failure, but really need to be carefully considered, and guideline-directed medical therapy continued. Those with persistent heart failure and those where things progress and have worsened heart failure. So the trajectory is very important here. Next slide, please. The diagnostic algorithm very much utilizes clinical diagnosis of heart failure assessment. Natriuretic peptides are important, echocardiography. Next, importantly, classification of heart failure once the diagnosis is confirmed still utilizes ejection fraction. So it's important to determine the cause and classify, evaluate for precipitating factors, initiate treatment, and perform serial assessment. Next. And what you can see builds here is with ejection fraction, that classification is heart failure with reduced ejection fraction, 40% or below. Next. The middle category that previously was considered mid-range is now referred to as heart failure with mildly reduced, but still defined as EF 41 to 49. Next. And heart failure preserved EF 50% or above. But importantly, and especially in response to medical therapy, there can be improvements in ejection fraction. So we now have that group of patients that are still categorized as heart failure reduced EF, but where their EF is now above 40%. And this is a group where it is critically important to maintain guideline-directed medical therapy. So this classification by EF, you'll see, will be critically important for the specific medications that are recommended for the patient population. Next slide. So from our diagnosis and classification, of course, that clinical diagnosis is critically important, and thus there's a class 1 recommendation regarding a complete history and physical exam with tips here, especially with a focus on identifying cardiac and non-cardiac diseases that may contribute. Also, evaluation of social determinants of health is important. Class 1 recommendations for laboratory and ECG testing, including CBC and other critically important labs, 12-lead EKG, consideration and morphology, as well as QRS duration, as well as rhythm. And then for patients presenting with heart failure, the specific cause of heart failure should be explored with additional laboratory testing for appropriate management. Next, please. Now, there is, for evaluation of patients with dyspnea, natriuretic peptides have a recommendation being useful to support a diagnosis or help exclude heart failure. For individuals at risk for heart failure, there's a recommendation at the 2A level for natriuretic peptides as a way of screening those at increased risk, and then guide referral to a cardiovascular specialist to then assist with risk factor modification and treatment to prevent heart failure. Hospitalized patients for risk stratification and diagnosis, there were recommendations, and likewise in chronic heart failure. But what you'll not see is recommendations around serial testing for natriuretic peptides, since clinical trials have not demonstrated improvement in outcome with that. And there are reminders about potential non-cardiac causes for elevated natriuretic peptides. Next slide. With regards to cardiac imaging, there's specific recommendations regarding chest X-ray, transthoracic echocardiography. In select patients, the use of cardiac CT, MRI, SPECT, and PET. Ischemia evaluation gets a two-way recommendation. And that it's important, in the absence of any clinical status change or being considered for additional procedures or otherwise, routine serial echocardiography is not recommended. There needs to be specific reasons. Next slide. As we look at the invasive evaluation of patients, invasive hemodynamics, there's a recommendation at a 2A level for select patients with persistent or worsening symptoms in whom where hemodynamics are uncertain. Invasive hemodynamic monitoring may be useful to guide management, but routine use not recommended. And also recommendations for endomyocardial biopsy. Next slide. Now, importantly, the treatment for stage C and D heart failure has really undergone substantial evolution here. And most important, moving beyond triple therapy is now the SGLT2 inhibitors for heart failure with reduced EF getting a class 1 recommendation. Another important change is the recommendation to start with sacubitril/valsartan, the angiotensin receptor neprilysin inhibitor, preferentially over an ACE inhibitor or ARB, and concomitant use of beta blocker and MRA therapy after having a diagnosis and confirming an EF of 40% or below. Guidelines actually recommend trying to start these therapies early and as soon as possible in stabilized patients. They do not specify the exact order or sequence that they be initiated. In some patients at low dose, starting all at once may be appropriate. In others, a serial strategy can be utilized. That exact ordering is left to individual clinician judgment. Diuretics have loop diuretics of class 1 recommendation, but as needed to manage volume overload. So this is the top line therapy, quadruple therapy, all eligible patients without contraindications with heart failure with reduced EF. Next, you can see that building upon this, we need to then up titrate to target dosing, and once achieving that, to then reassess ventricular function and then make further determinations. So throughout the management and trajectory of these patients, we want to continue guideline-directed medical therapy, have serial reassessment, and optimize dosing adherence and patient education. Next, we can see building upon this, though, there are additional therapies that may be considered based on specific patient phenotype or characteristics, based on their New York Heart class and other factors. And then we can consider things like hydralazine nitrates, ICD, and CRT, all with class 1 recommendations, but in very select patients. And then further consider next, select therapies for patients. And importantly, patients who remain refractory, then next we need to consider the more advanced therapies. And so, or palliative care if considered. So this outlines the foundation in a management of stage C and D heart failure with reduced ejection fraction. Next slide. So to emphasize, there are now 4 major classes of therapy that get the class 1 recommendation. Can refer to these as foundational medical therapies for heart failure reduced EF, can refer to them as the 4 pillars of heart failure medications for heart failure reduced EF, can refer to them as comprehensive disease modifying medical therapy, but these are now the national standard of care with a class 1 level of evidence recommendation for each. So sacubitril/valsartan recommended to reduce morbidity, mortality, one of the 3 evidence-based beta blockers. MRA as long as renal function is meeting the criteria specified in no hyperkalemia. And importantly, this new recommendation, symptomatic chronic heart failure reduced EF, SGLT2 inhibitor recommended to reduce hospitalization for heart failure and cardiovascular mortality, and importantly, irrespective of the presence or absence of type 2 diabetes as a fundamental heart failure reduced ejection fraction treatment. Next slide. So if we look at the additional therapies that may be considered after you optimize the foundational guideline-directed medical therapy, arabidine gets a 2A recommendation, vericiguat a new 2B recommendation, digoxin, omega-3 fatty acids, and then potassium binders for managing hyperkalemia at a 2B recommendation. So these additional therapies that may be considered, none of these, however, are recognized as foundational therapies that would be routinely applied as the quadruple therapy that I reviewed with you. Next slide. Now, there are specific recommendations regarding cardiac resynchronization therapy. These are very much in line with what previously existed in the guidelines. What is critically important, the emphasis with regards to optimizing guideline-directed medical therapy being very important for these patients. And so the general health status evaluation of comorbidities such that there's nothing that's going to limit survival to less than 1 year from a non-cardiovascular comorbidity. The guideline-directed medical therapy should be continued. Next slide, across the board here. So in those patients where that EF meets the specification, we can consider the therapies for these patients. Next slide. So mainly the class 1 recommendation is class 2 to ambulatory class 4 heart failure with left bundle branch block, QRS 150 and above, CRT being recommended. And then there's some 2A and 2B level recommendations. Next slide. So there are some special circumstances to consider that are highlighted here. Next slide. And for EFs 36 to 50 only, if there's high degree or complete heart block at a 2A level is CRT recommended. Next. So these are the recommendations regarding CRT. There are additional therapies that may be considered, so surgical revascularization in patients that meet the criteria specified here, severe secondary MR, but critically after optimization of guideline-directed medical therapy can consider then edge-to-edge device repair in these patients. And then for those patients with New York Heart Class 3 history of hospitalization for heart failure, elevated natriuretic peptide levels, wireless PA pressure monitoring at a 2B level. Next slide. With regards to the approach to treatment of secondary MR, the guidelines really emphasize critically important guideline-directed medical therapy optimized and supervised by a heart failure specialist before considering the secondary MR intervention. Patients undergoing CABG may be considered at that time. Next slide. But if meeting all these criteria and very consistent with the valve guidelines, that then patients may be considered for edge-to-edge repair. Click again for me. And you can see here then the EF less than 50%, persistent symptoms despite optimization, and then can consider the interventions. Next slide. So here, if yes, that edge-to-edge repair at a 2A level. Okay, next. So what about patients mildly reduced LVEF? We now have specific recommendations for them. So these are the mildly reduced with EFs 41 to 49, symptomatic heart failure, diuretics is needed, but here an important 2A recommendation for the SGLT2 inhibitor. So this is really critically important. So patients now have a specific therapy recommended to reduce cardiovascular death, heart failure hospitalization for heart failure with mildly reduced ejection fraction. At the 2A level, that is the only med recommendation. At 2B level, the ACE, ARB, or sacubitril/valsartan, MRA, and in specific circumstances, evidence-based beta blockers. So really important for this patient population. And we want to prevent these patients from progressing and reduce events. Very importantly, though, I want to emphasize, as it is on this slide, for those where the EF started off 40 or below and is now improved, those patients need to continue on the full contingent of guideline-directed medical therapy. That's a class 1 recommendation. Next slide. For patients, heart failure preserved EF, shown here. So these are symptomatic heart failure, EF 50% or above, diuretics is needed. And here again, the 2A recommendation for the SGLT2 inhibitors and recommendations for sacubitril valsartan at 2B, MRA, or ARB. So we really have now specific medication recommendations for the patient population, really importantly at a 2A level, a recommendation for SGLT2 inhibitors, given the really important findings from the Emperor Preserve trial. So really, landmark and breakthrough to now have specific medication recommendations at the 2A level or higher for those with mildly reduced and preserved ejection fraction heart failure. Next slide. So with that, let me now turn it over to Clyde, who's going to take us through the adjunctive therapies, comorbidities, and the acute decompensated heart failure patients. So Clyde, let me turn it over to you.
Greg, thank you very much. I hope everyone can hear me without difficulty, and terrific job bringing us through the nuts and bolts in the treatment of heart failure and reviewing the setup of the new HAACC-HFSA heart failure clinical practice guidelines. Repetition is the best way of learning. And let me just highlight some things that I hope what is now about 700 attendees will take away from the brilliant information Greg just transferred to you. Start with where he ended. We now have this new phenotype, heart failure with improved ejection fraction. That is for the good. We need to keep that in mind as we go forward. Also, think about the definitions of heart failure, the partitioning or the ejection fraction, what we understand now about the patients we see and how we approach them. Emphasize the importance of foundational quadruple therapy. This is not just phraseology. We now have very effective therapies, all of which benefit patients and improve outcomes. And in aggregate, we have any number of data sets now to tell us that our patients can do better with heart failure than they've ever done before. Collectively, between the two of us, we have over 6 decades invested in heart failure care, and it's never been as good as it is right now. So this is great information for you to digest and move forward. And finally, realize that these guidelines were developed directly with patient input, specific with patient participants as part of the guideline writing committee. So I think you should know this and recognize the uniqueness of this guideline statement. Let me extend these conversations further by discussing adjunctive therapies, important comorbidities, and then hospitalized heart failure to give you the complete picture as it appears in these guidelines. The first thing I'll deal with is a very important comorbidity, which is cardiac amyloidosis. It oftentimes presents as if the patient has conventional heart failure, but it takes an index of suspicion to understand the necessity to look for what we call TTR cardiac amyloid. The algorithm is developed for you on the screen. I won't dwell much, but I will tell you that this is not an orphan illness. Every major activity that is referral practice for heart failure has a representation of a patient cohort with cardiac amyloidosis, particularly TTR. It starts with a suggestive history. One takeaway: bilateral carpal tunnel syndrome. Think very carefully about obtaining a light chain assessment to see if there might be reason or rationale to go forward with a study for the evidence of cardiac amyloid, specifically a technesium pyrophosphate scan, quickly involving hematology oncology, especially if the scan is negative but the light chains are positive, making the bifurcation between AL amyloidosis and TTR amyloidosis. We do have an effective therapy for amyloidosis as depicted on the screen as you see it, that is specifically tafamidis. It is of low economic value. That's not to say that it's not effective. It does change the natural history, but value as a function of cost and benefit unfortunately weighs more towards low value because of what continues to be a very high cost profile. But if we're able to identify the likelihood of TTR amyloid, again, based on the history, the light chains, the demonstrable light chains, and a positive scan, then we should go forward and understand TTR gene sequencing. This helps us understand if it's wild type or if it's mutant, and we can then advise the family members. This elegant algorithm is embedded within the guidelines set. You should be able to download it from the right side of your screen, as Kelly mentioned earlier, but this is worthy information. And tafamidis is only the first of therapies targeting amyloidosis. Tafamidis prevents the misfolding. Future therapies will silence the production of amyloid at the level of RNA. Exciting times in science, and certainly exciting times for patients that have a condition that previously was untreatable. Let's go beyond that one particular concomitant other illness and think about the patients with advanced heart failure. For some number of years now, we have reintroduced different iterations of this very important patient-centric algorithm. I need help. If you deconstruct the algorithm, you can see how important each letter needs to be, as each letter serves independently as a prompt for consideration of referral to advanced heart failure. These guidelines endorse once again the importance of this patient-centric algorithm. I need help. Let me also share with you that this guideline really exercised a rigorous review of available evidence. Why do I say that? Because for two things that are incredibly important, one is sodium restriction and the other is fluid restriction, we realize that after decades of advocating the importance of both of these lifestyle adjustments, we have very little data to say they actually changed natural history. The most impressive data on sodium was just released by Justin Ezekowitz and colleagues in the sodium HF trial. The clinical outcome on mortality and hospitalization was null, but the benefit on quality of life was modestly important. This does not mean that we should liberalize salt intake, but it demonstrates how difficult it is to do this kind of lifestyle-based research. We are unable, let me say this again, we're unable to specify the extent to which salt restriction should occur, but clinical judgment should prevail. By the same token, we're unable to be clear on the exact amount of fluid restriction. No patient should be allowed to go thirsty, but we should understand that hyponatremia is a major problem. In previous guidelines, we've advocated use of the vasopressin antagonist, and that may be something that you want to consider. What about patients hospitalized with decompensated heart failure? This is vitally important. Dr. Fonarow and I will tell you that the events are still well over 1 million episodes per year. It's critical that the evaluation include a search for precipitating factors, understanding the severity of congestion, and identifying the adequacy of perfusion. If you will, a good bedside exam. Did you feel the extremities? Did you check for edema? Did you raise questions about belt marks? Did you raise questions about sacral edema for those that are lying down or seated all the time? What are your goals of care? How many times do we have this conversation? What are your goals of care, not just end of life, but upon admission? Optimize the volume status, address the reversible factors, and critically important, continue or initiate guideline-directed medical therapy. You should know that amongst the quadruple platform that Dr. Fonarow advocated, we have precise evidence that the earlier those drugs are instituted, the better. The lines of distinction in the clinical trials began to deviate within the first 30 days. And so the hospitalization environment is an excellent place to consider initiating quadruple therapy, if not already in place. What are the usual factors precipitating heart failure and hospitalization? Well, the guideline becomes a primer and tells you what kinds of things to suspect. Frequently in my own clinical practice, as I remain clinically active, just like Dr. Fonarow, we see acute coronary syndromes, we see atrial fibrillation, we especially see valvular heart disease. These are important considerations for your understanding and appreciation as you're managing these patients. What is a decongestion strategy? Well, first, what do you monitor? Daily weights have always been important, but beyond that, we need to pay careful attention to renal function, electrolytes, and clinical evidence of hypoperfusion. How do we do this? Almost invariably, it's with loop diuretics unless we're already dealing with renal replacement strategies. What are the ways in which we do this? This is a key consideration, and I'm delighted that we were able to place this in the guidelines. Take the daily loop diuretic dose. double it and make that the initial IV loop diuretic dose. This is evidence-based from the Heart Failure Clinical Trials Research Network. If we go beyond that, then we begin to think about sequential nephron blockade, which is a thiazide loop diuretic. It is a thiazide plus a loop diuretic and or a continuous infusion of loop diuretics, a frequent strategy we employ in our critical care unit here. The addition of an MRA can add to diuresis independently of the life-sustaining effect. And then sometimes the adjunctive administration of low-dose dopamine, you can see by color scale, not as highly regarded, is a plausible consideration. At the time of discharge, it's very important to offer diuretic flexibility. Let me reiterate something very important. Diuretics have never been shown to change the natural history of heart failure. This is for decongestion and for patient comfort. They do threaten renal function. So having a flexible strategy that allows us to de-escalate diuretics is incredibly important. What about guideline-directed medical therapy during hospitalization? Admission, as I've already identified, during the inpatient process, understanding there may be some mild reduction in renal function, please don't call this AKI. Please recognize that it's highly variable. If it's a significant change, that's important, but we expect to see some fluctuation. But then pre-discharge, make certain the diuretics have been reestablished as necessary to maintain a euvolemic state and are working in concert with guideline-directed medical therapy. You see the 4 class 1 recommendations with level of evidence A for the use of the foundational therapies. We can't reiterate that enough. An appropriate diuretic regimen on the backdrop of quadruple therapy is state-of-the-art for the treatment of heart failure. What about transitions of care? We've realized this is where we've lost many patients. So this should include early follow-up, evidence-based within 7 days. That can be a phone call if necessary. A multidisciplinary heart failure management program should be an active process. It's a class 1 recommendation. Not always available in every center, and different iterations may qualify as a multidisciplinary heart failure management program, but it's a class 1 recommendation. Class 2A is participate in benchmarking programs that identify quality of care. The others you can see there for your perusal. What are the additional therapies in patients with heart failure and comorbidities? Almost invariably, this is the thought process for that hospitalized patient. What about when concomitant hypertension is present? What about when type 2 diabetes is present? What about the patients that have reduced CF heart failure in suitable coronary anatomy? What about those that have valvular heart disease? What about those that have obstructive sleep apnea? What about those that have atrial fibrillation? There are a variety of opportunities to change the natural history of our patients by paying careful attention to their concomitant comorbidities. Let me speak even more explicitly. There are 10 additional therapies depicted on this graphic for different clinical representations that are common in everyday practice. And so we should all be as facile with these 10 guideline-directed steps, 5 of which are class 1, 5 of which are class 2A, for the purposes of improving the natural history of our patients with heart failure. What about managing those comorbidities? Do recognize the importance of identifying iron deficiency, understanding the importance of hypertension, management of sleep disorders, if for no other reason than improve sleep architecture and rest, and management of diabetes, particularly with the SGLT2 inhibitors available. What about atrial fibrillation? This is team medicine, team management. So quickly incorporate your peers in electrophysiology. But there are 2 class 1 recommendations, predominantly for the use of anticoagulant therapy. Another conversation, both Dr. Fonarow and I can tell you with great certainty that this is still a recommendation for which there is failure to see adequate adherence. And unfortunately, that adherence is many times a function of age, a function of sex, a function of race. And so please recognize the importance of anticoagulation in those with atrial fibrillation. You can see the 2A recommendations here as well. This is a part of a guideline for which I am quite enthused. We've not ever before been able to incorporate value statements in a clinical practice guideline. This heart failure guideline is the first iteration of this new model. I briefly mentioned in the conversation about tafamidis that value is the relationship between the clinical benefit and cost. Obviously, some things will have a very high value, others will have an intermediate value, and others will have a low value. Tafamidis is a prototype for low value. What about intermediate value? Well, it turns out the SGLT2 inhibitor falls in that space. Still proprietary. Prices are still high. It's important for us to work carefully with all the resources available to make this drug available. But the value statement is at intermediate value. The benefits are unquestioned, cost is a concern. But for all the other therapies that are particularly a part of quadruple therapy, the value statement indicates high value. And this oftentimes is necessary when we are appealing questions of cost with third-party carriers. This is another space for which I think we've done a credible job in the generation of the clinical practice guidelines. The first, we've talked about the vulnerable populations. When you go through the vulnerable populations, it goes beyond the prototypical populations identified as a function of race or ethnicity. What about persons with movement disorders? What about persons in the LGBTQI categories? What about patients that are transgender? There are an increasing number of patients that represent a broad diversity of those who have cardiovascular disease, including heart failure. There's a class 1 recommendation to be fully aware of the diversity of our patient cohort, and a class 1 recommendation to seek evidence of health disparities, monitor that evidence, and move forward. Certainly, if this question comes up in our Q&A, there's new information I can give you about strategies to help mitigate disparities. Performance measures. Dr. Fonarow and I were co-authors of the foregoing heart failure performance measures document that now has been incorporated into the clinical practice guidelines. These are the measures against which your hospital's quality of care for heart failure will be judged. So all of you as representatives of your hospital should be facile with these performance measures. What are the goals of care? You've heard this word before, but this particularly looks at the back end. The first was upon admission to the hospital, but looking at patients that have more advanced disease and realizing that these are necessary, even obligatory conversations, the guidelines give you a template for how do you approach goals of care, what are the important conversations that you should host. Patient-reported outcomes, we were ecstatic in the development of the performance measures that for the first time we could bring forward as a measurable performance measure a better calibrated and a more specific assessment of patient-reported outcomes. We are specifically making reference to using the KCCQ enterprise or instrument. This is in addition to your NYHA classification, but it gives us an opportunity to start with NYHA class and extend as necessary. There's brilliant information within the heart failure with preserved EF space that we can use the KCCQ to not only study the symptom burden, but also to gauge the response to medical therapy. So this is a new aspect of heart failure care that should be incorporated in your practices. This is another space that I am particularly enthused to see in the guidelines. We decided not to guess, and we decided to step away from empiric statements and rather say there are some things, some issues in heart failure for which we simply don't have evidence. For example, dietary interventions. For example, invasive therapies, interventional approaches to arrhythmias, nerve stimulation and ablation. There are any number of therapies that actually carry FDA approval for which we're not able to articulate how best to use them in the guideline because the evidence base doesn't meet that bar. And so recognize that we're already setting the stage for ongoing research in the next iteration of the clinical practice guidelines. I'm going to finish this up by going through the top 10 things to know about the guidelines. This will be fairly quick because we'd like to preserve at least 10 or 15 minutes for your questions. And I hope that you are capturing questions as Greg and I have gone through this information. So top 10 things to know. Let's think about Jimmy Fallon and This Is the Tonight Show. Here are the top 10 things to know. Or was that David Letterman, Greg, who used to do that? I think it was Letterman. All right, let's start. Number 1, guideline-directed medical therapy for heart failure. Now it's a 4-compartment approach. There is clear evidence that quadruple therapy changes natural history. SGLT2 inhibitors go beyond the therapy for HFrEF and now include heart failure with mid-range ejection fraction. For the first time, we can articulate a therapy with evidence to suggest benefit. There are additional other therapies for heart failure with mid-range ejection fraction that Gregg summarized and appear here. Number 3, HFpEF. This really is a pause moment. Any of you in the audience that have been involved in heart failure as long as either Gregg or myself understand that we've not ever been able to say anything other than treat the concomitant comorbidity. We had a soft indication in the previous guidelines for the MRA therapies, but now we have a more solid recommendation for the SGLT2 inhibitors, for the mineralocorticoid antagonists at 2B, and for the RNA compounds at 2B. We still don't have a therapy that improves mortality, that is cardiovascular mortality, but heart failure-related cardiovascular morbidity now demonstrates responsiveness to the therapies as you see here. What's the fourth take-home message? It's very important to understand that there is this new profile that we never really identified before. Patients that have heart failure with improved EF, remember, they start with an EF less than 40%, substantially so, realize at least a 10-point increase, and that 10-point increase yields an EF greater than 40%. Not only should you respect exactly what Dr. Fonarow said, continue evidence-based therapy, but also appreciate that the natural history for this group may be slightly different. A lesser risk for mortality, a lesser risk for hospitalization, but not zero, and certainly not a zero risk for sudden cardiac death events. So ICDs remain intact, evidence-based therapies remain in place, perhaps simplified, but suffice it to say, this patient population has a better natural history. And once we understand the biology at play and can manipulate it, this might be another frontier for heart failure. What's number 5? I've already highlighted the importance of the value statements. What's number 6? I've already highlighted the importance of thinking about amyloid heart disease and realize that we're right at the precipice of a sequential series of new therapies to address this. One therapy is available now, but others are to come. It starts with a clinical assessment and then screening, looking for light chains, followed by bone scintigraphy and genetic sequencing. This is fairly sophisticated stuff, but it's available in most major medical centers. Number 7, understanding that evaluating evidence of congestion in patients with ejection fractions above 40% is important. We have some tools, but we don't have definitive evidence that those tools change natural history, but they do inform what we should do. Specifically thinking about non-invasive assessment of docile performance and thinking about invasive testing up to and including implantation of the pulmonary monitor. Even invasive measurement in a cath lab has an informative position, yes, but the ability to change the natural history is not clear. Nevertheless, we believe it is important to seek evidence of congestion for patients with an EF greater than 40% and then use best clinical judgment. Number 8, for patients with advanced heart failure who wish to prolong survival, this falls into the realm of I need help. Those patients should clearly be seen by a specialized team that can go through the entire portfolio of advanced heart failure therapies. It goes beyond just organ transplantation. Palliative inotropes are not inappropriate for an older patient or a patient that is not amenable to major surgical procedures. This may be a way to improve quality of care, meet the patient's goals of care, and not extend survival, but extend quality time. Number 9, primary prevention is key. We have evidence like we've never had before that if we initiate the early use of SGLT2 inhibitors, if we screen with natriuretic peptides in patients that are cardiovascular risk and start evidence-based therapies in the stage A population, we can make a difference. In the stage B population, particularly when the natriuretic peptides are elevated, once again, we have evidence that we can make a difference. And in certain stage B cohorts, we know that we can make a difference even if they're asymptomatic. So this should not be overlooked. And the 10th one, understand that for select patients with heart failure and a number of other concomitant conditions, again, we have therapies with evidence to indicate that we can improve the outcomes for those patients. Before I go into questions, let me thank Kelly for her opening comments attributed to both Greg and me. We have been at this a while, but we've been at this a while because we have a passion for treating patients with heart failure. We appreciate the partnership with American Heart Association. We appreciate the contribution of the Get With The Guidelines Heart Failure platform and its different iterations to improving care. And Greg and I would be delighted to spend the last 10 to 15 minutes answering your questions. Thank you.
Wonderful. Thank you, Dr. Yancy and Dr. Fonarow. Now we'll begin the answering the question and answer period that were submitted during today's presentation. As a reminder, you guys can still go ahead and submit them, and we'll be entering them. We did get a lot of questions throughout the presentation, so I will start and kick it off. So one of the first ones that came through are the contraindications for SGLT2. What are they?
Great. I'll start with that, and Clyde can add. So importantly, there are very few. Type 1 diabetes, which is a very small proportion of our patients with heart failure, we really don't have enough evidence of safety yet, so that's an important consideration. These agents can be started down to a GFR of 20 or higher, so we don't have data for those on dialysis. But really, from that standpoint, those are the contraindications. They're very few. Now, side effects, they were in the clinical trials as well tolerated as placebo. There were actually more adverse events with placebo in some of the trials. There is a very small risk of diabetes-related ketoacidosis that was not seen in those without type 2 diabetes, and likewise, risk of hypoglycemia was not seen in those without type 2 diabetes. There is a modest increase in genital fungal infections, just need to discuss that with patients, but these are incredibly safe and well tolerated, but importantly, highly effective drugs that work within days of being initiated in patients with both reduced, mildly reduced, and preserved ejection fraction.
What I'll add to this is not an extension of the risk, but a heightened awareness of the importance of this question. Just early this morning, as I was beginning my day, there was a television advertisement for empagliflozin, and the list of potential consequences or side effects was very plain spoken and, quite frankly, a little bit disconcerting. And so you can expect that your patients will come in because they indeed have been informed through public media to be very concerned about infections, to be very concerned about severe episodes of acidosis. And so be prepared for these questions. Understand that the limitation really is for type 2 diabetes, which reduces that incidence of acidosis. Understand that the severe infections are peritoneal infections. Frankly, appropriate hygiene prevents most of that, but be prepared because the patients are already pre-informed, just courtesy of public media.
Okay, great. A next question is, it's along the medication line for that too. How can Get With The Guidelines help to monitor the use of these new medications in the guidelines?
Yeah, so Get With The Guidelines is in sync with the new guideline updates. So all of the class 1 recommendations are there as quality or achievement measures. There actually is a quadruple therapy measure, so you can look in aggregate regarding the use for eligible patients. The monitoring detection of comorbidities, that data is collected. So really all of the key elements of the guidelines have been integrated and Get With The Guidelines, tracking your progress and compared to benchmark groups. So it's interesting, the guidelines themselves recognize and recommend participating in performance improvement systems like Get With The Guidelines heart failure. So there's been a very close synchronization. This can really be a critical way for you to really make a major effort to improve the implementation of the guidelines, be able to track that and provide feedback, benchmark feedback to all clinicians.
And to extend that one step further, I'd love for this audience to know that there is an extension of Get With The Guidelines heart failure known as Implement HF, a program that is capturing additional data points, particularly 30 days after hospitalization. We will be better informed than we've ever been before about the adequacy of alignment with the guidelines, and we will specifically evaluate not only quadruple therapy, but quality of care for patients with HFpEF and mildly reduced ejection fraction. So this will be a very interesting project, and our overt pre-specified goal is an absolute reduction in the risk of death by 5%, because we have that much conviction that quadruple therapy will work. And so whomever raised that question, it will be also informed by the results of IMPLIMENT-HF.
Great, thank you for that, Dr. Yancy and Dr. Fonarow. Another question came in: why is LVSD now considered with an EF of 40% or higher? Why does the 1% make a difference with the change?
So we obviously, in categorizing EF, need to make a cut point, and that's very important. The clinical trials have enrolled in heart failure reduced EF for EFs 40% or below. Some guidelines were a little loose with that and used to say less than 40. So 40 and below, we have very strong evidence in those recommendations, 41 to 49. Now, that's a degree of precision where often the echo is read within a 5% range where they'll say 40 to 45. So you need to use some judgment there, but based on the criteria for clinical trials, based on the actual results we've seen with these therapies, that is why the categories exist. But it's important for the clinician to understand there is some variability that exists on who's reading that echocardiogram, or whether you're comparing EF from an echo versus a CT versus MRI versus LV gram, and take that into account utilizing your clinical judgment. So there is a degree of precision implied here down to single digits that may not fully exist, but as a general guide can help frame the therapies that are being applied.
And then recognize that this question really opens up just a brief statement about our efforts to go beyond the measurement of the ejection fraction to qualify LV dysfunction, whether we're talking about systolic or diastolic. Increasingly, we're becoming facile with global longitudinal strain measurements from the echo lab. Increasingly, we're paying careful attention to the cardiac MRI. What is the extracellular volume? What is the replacement fibrosis? What do we know about delayed enhancement? I think we will emerge into a space where we look at a portfolio of assessments of ventricular integrity as opposed to performance, and use that to enable our decision-making about ICD use, about the rapidity with which we institute evidence-based therapy, even about the decision to proceed forward with advanced therapies. The ejection fraction is not sufficient to really calibrate prognostically what will happen to that patient. So an insightful question, I believe, and an answer that we continue to explore.
Okay, great. Can you speak to the strategies to increase MRA usage? Any model sharing best practices on how to support providers and remembering to consider the MRAs?
So I'll start. We highlight and get with the guidelines that despite the class 1 recommendation, only about a third of perfectly eligible patients were being treated. And part of this was gaps in knowledge and awareness, but a lot of it was fear of hyperkalemia and the importance of monitoring. So building in systems to where you can reliably follow up and measure potassium in these patients is key for prescription. Starting off on lower doses, spironolactone 6.25 or 12.5 in those with moderately impaired renal function can be another strategy that can be utilized. And we have seen progress within Get With The Guidelines. There are many centers now where about 50% of their eligible patients are treated. And in Europe, there are many centers where up in the 80 or 90% range. There are now the class of potassium binders that get a 2B recommendation in the guidelines. So much of this is building that reliable system to be aware to initiate an appropriate patient at appropriate dose, but also have that follow-up and monitoring and education of patients regarding avoiding the risk of hyperkalemia, detecting it, and being able to manage it with appropriate dose adjustments or adjunctive therapy.
And the only two things to add to this is that, yes, we do have the potassium binders, but we still are waiting for clinical outcomes data with those drugs. But importantly, there was a statement I made earlier that I'd like to highlight: the importance of transitioning the care of a patient to a multidisciplinary team. That is the best strategy to capture these episodes of hyperkalemia after initiating an MRA agent. And so if there is in fact a system in place, Gregg and I are both champions of process improvement. Build a process first, and the process will take care of the downstream assessment of potassium. Critically important. But I think the fear that was expressed some 15 years ago about hyperkalemia has yielded to the benefit of these agents, and we should not hesitate to use them and use the strategies that are available, potassium binders if necessary, but in particular the multidisciplinary team to really massage this concern.
And one other critical point I will add, sacubitril valsartan, a lower risk of hyperkalemia with MRAs compared to ACE inhibitors, and SGLT2 inhibitors, a lower risk of hyperkalemia with MRAs when used together. So actually, all four medications together help modulate that risk and can give clinicians more confidence in their use.
Okay, another question, it just came in along the MRA, so we'll stay on that. They're asking, is one MRA more effective than the other?
Well, I'll give you the guideline answer, and I appreciate Clyde's input as well, and that is we don't have head-to-head comparative trials. If we look at the two major trials done with regards to heart failure reduced EF, both lowered all-cause mortality, RALS and emphasis HF, so spironolactone or eplerenone. From a tolerability standpoint, clearly less issue with regards to gynecomastia with the eplerenone. And of course, there are some newer non-steroidal based MRAs that will be studied in patients with heart failure, currently indicated in patients with type 2 diabetes and chronic kidney disease. So more information will be forthcoming about classes within MRA, but currently the guidelines make that class recommendation. Clyde?
Yeah, stay tuned for data using finerenone, but also look out for the Transform HF clinical trial results. That is another way of trying to manipulate potentially an anti-aldosterone-like effect from other indicated therapies. So this question will continue to evolve.
Okay, great. Another question just came in. Any changes in recommendations for advanced therapies?
So Greg, let me go with this one first, because I think everyone needs to appreciate the following. There's never been a randomized controlled trial for heart transplantation. And so it is an accepted strategy because patients are so desperately ill. For mechanical circulatory support, let me again speak very clearly to this. There is only one platform available for clinical use. The field is narrowed because of ongoing concerns of, and I'll say this delicately, harm. That's not to say that research doesn't continue. In fact, a large grant was just awarded to a major university to explore a wireless mechanical circulatory support system. Where we continue to acquire evidence, though, is in quality of life with mechanical circulatory support. The field has come far. And though we have only one platform, we have much less risk of stroke. We are improving rates of infection just by process improvement. We are managing the bleeding complications just by process improvement, continuing to explore the science behind this. And so recognize that life with a mechanical circulatory support device is not easy, but it's better than it's been before. Nothing could be more important than a shared decision-making moment and a well-informed team that really respects the wishes of the patient. There are some non-branded patient education materials out of the University of Colorado. We've supported those that really allow patients to have an unbiased view of the potential benefits and risk of mechanical circulatory support. Avail yourself of these products. An LVAD is irrevocable. Once it's in place, it's in place. So this is a very important conversation. I usurped our order because I've seen too many cases where patients, in retrospect, probably didn't have the benefit of a full educational experience before going forward. That's not to impugn or align anyone. It's simply to say these are tough conversations, and teams need to be prepared to spend whatever time is necessary to allow a patient to become fully informed up to and including speaking to other patients with devices, and importantly, to family members of patients who succumbed to devices, so the patients can make an informed decision. This really is key for the American Heart Association, for patients to have a voice in critical decisions like this.
That was brilliantly stated. And I would just add, I mean, the onus is upon us to prevent patients from getting to this stage, preventing heart failure in the first place, and really maximizing our guideline-directed medical therapies and management of comorbidities so patients do not advance to stage D. And never have we had more tools to be able to do that. If we effectively implement the guidelines, we will dramatically reduce the number of patients where even device therapies such as transplant are considerations. And that onus should be upon all of us to really implement these guidelines aggressively.
So Kelly, without the prompt, Gregg just dropped the mic on this webinar.
Okay. Well, thank you. We will continue to answer the questions that we have received, and we've received a lot of great questions. So thank you all. And I want to thank Dr. Yancy and Dr. Fonarow for the wonderful presentation today. I think it was very informative. We all learned a lot, and I would just like to thank you on behalf of the American Heart Association and our presenters. Thank you for joining us today, and I hope you have a great rest of your day. The recording will be available within 24 hours, and also the handouts and the PowerPoint that they shared today on the new guidelines for 2022 will also be available. So we will send those out. And once again, thank you for today. Have a great day.